and critical care specialist at the University of Toledo Medical Center. And this is my lecture about pulmonary function test. I'd like to welcome everyone. If you have any questions, I will be looking at my messages so that I know that if you have any questions, I can answer these questions during the presentation. So let me see just how I can check my messages. Okay, I can see the messages now through, okay, very good. So if anyone has a message, please text me. So raise your hands if you can hear me, everyone. Can you raise your hands if you can hear me? Okay, good, thank you. Okay, so today I will talk about the PFT, so review the indications, conduct, and interpretation of pulmonary function testing. I will highlight the limitation of various measurements. I will review the characteristics of the pulmonary function test results and interpretations. So first, before you do the pulmonary function test, you need to and have some consideration for the testing. So the first thing you look at is the patient, and then your laboratory and equipment, your laboratory personnel, reference values, quality assurance, and I will talk in details about that. And then you have infection control and safety, and then testing and procedures. Usually anyone who is coming to the pulmonary function test lab, we have them do the PFT themselves. That way they can understand the test and how to interpret the test. So for the test has many parts. One of them, we call it spirometry. And then the next one, we call it lung volume and diffusing capacity. For spirometry, in the United States, it is a reference values. So what they did is that they studied a lot of healthy individuals from the age of 8 and 80, and they look at the reference values for these individuals, and they decided on what are the normal values for the PFT testing, for the values of the spirometry and the lung volumes and everything. For the lung volumes and diffusing capacity, they did not specify certain values, but they have some equations that relate the lung volumes to the height and the weight of the individual. So remember, lung volumes usually related to the height. So the taller you are, the larger lung volumes. And it doesn't have to do with the weight. It has to do with the predicted body weight. So this is just something important to remember. So it's not that obese patients have larger lung volumes. It's tall people that they have large lung volumes. Now I want to just specify some parameters for you guys to understand what happens to the lung function test as we age. Okay, so remember what happened is that the functional residual capacity increased with age, because the RV, which is the residual volume, increased with age because of the elastic recoil of the lung decrease. Once the elastic recoil of the lung decrease, that leads to the residual volume to increase with age. And once the residual volume increase, remember the total lung capacity is a summation of the vital capacity and the residual volume. So if the residual volume increase, what happened to the functional residual capacity, to the functional vital capacity? It decreased with age. Okay, same thing for the diffusing capacity. So these are things to remember, and that's why aging population, the pulmonary function test becomes limited, and that's why we choose different numbers when we look at elderly. So anyone above the age of 60, for obstructive lung disease, we don't look at FEV1 over FVC ratio of 70. Their normal FEV1 over FVC ratio actually declined to around 67. And therefore they have something we call dynamic obstruction, and therefore the reference values that we need for them is less. Remember, males have larger lung function than females. males have larger. And I said tall individuals have larger lung function and males have larger lung function because their chest wall and their muscle volume is bigger, and therefore all their lung volumes and their expiratory and inspiratory pressures are larger, males than females. Tall individuals, I mentioned about that. Now, what happened to the lung function test as we age? You need to, if you monitor your lung function test every year, you will see that the best lung function that any human being will achieve is at age of 20 to 30 years. So after that, all lung function begin to decline. So the best FEV1 and FVC you will achieve at age 30 years. After that, every year, your lung function will decrease by 30 ml per year. So if a normal FEV1 is 3.5 liters, after that, it decreased by 30 ml per year. So every 5 years, you decrease by around 150 ml. So every 10 years, around 0.3 ml. Every 20 years, it decreased by around 0.7 liters, and after 25 years, around liter. So at age 30, if your normal FEV1 is 3.5 liters, at age 50 to 60, your FEV1 will become around 2.5 liter. So that's, remember that as well. Now, for serial testing, what we do is that we compare the patient's value, his previous value, PFT, we compare it to the same value that the patient did. So always remember to choose the same value. So what do you do? What does the pulmonary function test entails? So the pulmonary function test, it entails around 6 or 7 components. And each one component, you do it and you interpret sequential to each other. The first thing that we do is spirometry. And remember, in the physiology lab, the spirometry is just the act of, we call it an FVC maneuver, which means that you take a deep inhalation and then you exhale all the way until you reach the spirometry, which is this one. So this one is the spirometry. Okay, this is the spirometry, the same thing you did in the physiology lab, where we go in and out, in and out, in and out, and then you go out all the way and then in all the way, right? So this is the spirometry. Now, when you do this, this is time versus volume curve, we call it, time versus volume. When you plot it in a flow volume, that's how it looks like. So this is the spirometry. The spirometry, by the way, it's the easiest part of the pulmonary function test. It only takes 5 minutes to do. And all you need is to ask the individual, take a deep breath and then exhale all the way. And that's how you do a spirometry testing. So, and there are some portable spirometer that the allergists sometimes and certain clinics, they have them in their office, and even certain employment facility, they use that and they ask you to exhale, inhale, and then exhale in a device all the way until you empty your lungs. That is, we call it spirometry testing. And I will explain how to interpret the spirometry and what does the spirometry testing mean, okay? So this is the first part of the pulmonary function test, the spirometry and the flow volume loop, which I show you. Another part of the test, we call it bronchodilator response, which you give albuterol or beta-2 agonist, and then you see what happens to the pulmonary function test after you give that, and you see if there is some improvement, the FEV1, FVC, or there's no improvement. The other part, we call it lung volume. And lung volumes, we have many maneuvers to study lung volume and show how to do. And I will explain with you, I will show you how to measure the lung volume. The other part of the testing, we call it the DLCO testing, or diffusing capacity. And also there are 2 maneuvers to measure the diffusing capacity, and I will show you how to do that. Then we have something we call it bronchoprovocation testing, which is the opposite of the bronchodilator test. Instead of giving a bronchodilator, like beta-2 agonist, you actually give something to induce bronchoconstriction. Example of that, you can give cold air, you can give histamine, you can give methacholine, and all these are cholinomimetic agents that can cause bronchoconstriction, or histamine agonist, H1 agonist, that can cause bronchoconstriction. If you do those, then you are looking for a decrease or worsening of the FEV1 or FVC when you give these substances. Then we have two more testing that I will briefly explain in this lecture, which is something we call maximum respiratory pressures. And the maximum respiratory pressures, it can measure the maximum inspiratory and the maximum expiratory pressures. And those will measure the strength of your cough. So we measure that for anyone who's in the hospital who cannot clear his secretions. And the maximum inspiratory pressure, or we call it negative inspiratory force, NIF, test the function of the diaphragm and the inspiratory muscles. And this is important for somebody. If you want to extubate somebody, for example, you want to know how much they can generate inspiratory force. And any value above negative 60 is usually a good value, and that means that the patient can tolerate extubation. And then we have simple and complex cardiopulmonary exercise testing. The simple pulmonary exercise testing, which we call it the 6-minute walk test. And that test usually measures the oxygenation of the patient, and if it dropped with walking, and it also measures the heart rate and the blood pressure response. The complex cardiopulmonary exercise testing is more complex, and it measures more values such as oxygen consumption, the anaerobic threshold. It measures the metabolic clearance of lactate. It measures the dead space and other factors. And I will not talk about this in this lecture. So the spirometry, this is the first thing that I will discuss. So the spirometer must be capable of measuring a volume of 8 liters. So the maximum that anyone can generate in a single breath technique is 8 liters. And you can generate that in 15 seconds. So that's how the spirometer is set. Accuracy usually is plus minus 3%. And the airflow is 14 liters per second. So remember just those values. You can measure 8 liters in spirometer with a flow of 4 liters per second. Now, spirometry, usually we do not do just one value, okay? So remember, so for technique of the test, we need to do 3 values to measure a spirometry. And therefore, it is something that you have to repeat to make sure that it's accurate. Now, after you repeat the values, you want to make sure that the values are within 0.15 liters from each other. And this is mostly technique. So what you do in the pulmonary function test, you ask the patient or the individual to do something we call it FVC maneuver. And the forced vital capacity maneuver, as I told you, you take a deep breath and then you exhale it all the way. So that we call it FVC maneuver. If the FVC maneuver is accurate, then you have to repeat it 3 times, and after that you interpret your results. But this is more technical. So let's go to this slide. This slide is the most important slide of the lecture. And you will have a lot of board questions in the USMLE and also in the internal medicine board about this graph. So this graph, and I want to focus on the graph here. So this is what we call the spirometry, or the flow volume curve. Why do we call it flow volume curve? Because on the x-axis here, you see the volume, and on the y-axis here, you see the flow, okay? So this is the flow is here, and the volume is here. Now, where do you start? Usually, you start from a point which is here. Can you see my cursor? Okay, so you start from here. So this point that you start is you start from the residual volume. So the residual volume will be here, and you start from here. And what you ask the individual to do, you ask him to take a deep breath. So inspiration, full inspiration here, and then expiration here. So the inspiration will be in the negative part here. That's the inspiration. This is, we call it the inspiratory loop. And here is the expiratory loop. So if you start from residual volume and you full inspire, so what point you reach here? You reach a point, we call it total lung capacity, right? Because this is, the residual volume is here. You start from point here and you ask him to take a deep breath, breath, until you reach here. Once you reach here, that's the maximum inspiration of the lung. This is the total lung capacity. Once you reach the total lung capacity, now you ask him to expire forcefully and quickly as much as he can. So expire, 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 all the way until you empty all your lung and you reach the RV point. So this is the residual volume point. This is the total lung capacity point. This is the inspiration, and this is the expiration. Now, what point is this point? This point is, we call it peak expiratory flow rate. And this point is important in asthma because that's how you know if asthmatic individuals are in exacerbation or not, is about their peak expiratory flow rate, which is here. And remember, the peak expiration, the spirometer is 14 liters per second. Remember, this is the flow, liter per second. So this point maximum should be 14, but most people can get about 8, 10, okay? Now, a technical, after the peak expiratory flow rate, then you have the exhalation, which is the, we call it the exhalation, the non-forceful exhalation. Now, the question will be, if you look at this graph, where is the volumes? Where are the volumes? You do not know where are the volumes because this is flow. The volumes will be here. So you have the forced vital capacity will be from the point of the RV to the total lung capacity. So this is the forced vital capacity will be here. This is the forced vital capacity on the x-axis. Now, where is the FEV1? The FEV1 is this area here, because that's when, so you reach your peak expiratory flow rate, by the way, before 1 second. Once you reach a 1 second here, that's when you have the forced expiratory volume in 1 second. So this is the first second, and this area here on the x-axis is the FEV1. Now remember, this is a flow volume. Volume is here, flow is here. We don't know where's the time here. So that's why they put these markers, these columns for you to tell you that these are the time. So this one here is the time when you reach 50% of your exhalation. This is when you reach 25%, and this is when you reach 75%. So the 1 second will be just, you know, after the 75%. So this is the 1 second, and the FEV1 will be that area here. Okay, so, you know I am not there with you to explain it exactly, but remember that you see the area here. This is the forced vital capacity from here to here, and the FEV1 will be portion of that at 1 second, which is from here to here will be the FEV1. Now this is the FEF 25%, FEF 55%, FEF 75%. This is the volume of air that you can get out in 25%, 50%, or 75%. And these usually measure the small airway function. So the FEV1 measures the large airway function, and the FEF measures the small airway function. Now reversibility, what you do in this case, you give beta-2 agonist or albuterol to the patient, and you look for 12% improvement. Remember the 12% number. You may be asked about this number in your boards. If a patient have 12% number, then he is positive for bronchodilator response. If he didn't have his number, he is negative. So to diagnose asthma with a positive bronchodilator response, you need 12% positive bronchodilator response. Now, not only asthmatics have positive bronchodilator, sometimes COPD patients have positive bronchodilator response. Okay, so 12% improvement in the FEV1 mean that the bronchodilator response is positive. Now we are done with spirometry. Do you have any questions about spirometry? Raise your hand if you have questions, and I will answer it in your in my messages. Any questions? No questions? Okay, great. So then let's move on to measure the lung volumes. Okay, now the lung volumes, to measure it, we have something we call it body plethysmography technique, okay, or body box we call it. And what this is, it's very simple, okay. You boil law, if you remember boil law from physiology, the pressure times volume is constant, always constant, whether you're outside or inside. So what happens here is that they sit, all of you, you sit in a body box, which is a box that has amount of air, that you measure the amount of air in that box. And they measure the amount of pressure in that box. It's a closed glass box, okay? And then they ask you to breathe in and out, simple breaths in and out, and forceful breath in and out. Once you do that, what happens is that there will be change in the amount of air and pressure in the box. And these changes, they measure them, and they reflect the changes from outside of your body to the changes inside your body. And in that way, they measure your lung volumes and lung pressure, okay? The first measurement that they measure there, we call it functional residual capacity, which is the amount of air that remain in the lung after a normal tidal volume. And I show you how the functional residual capacity look like. Now, when you do this, this is the most accurate measurement of lung volumes. So the most accurate measurement of lung volume is the body plethysmography. Now, not all pulmonary function tests the laboratory have this technique. We have other techniques to measure the lung volume. It's not as accurate as the body box technique. This technique, we call it gas dilution technique. And it's very simple. What they do, they give you an inert gas. Inert gas means a gas that does not diffuse through your lungs. And they give you that gas because they want to measure the amount of gas that you breathe and the amount of gas that you exhale. And they don't want any gas to diffuse so that they can measure your lung volume accurately. And we have two gases that they do not diffuse. One of them, we call it nitrogen. We call it a nitrogen washout, or helium gas, or neon sometimes. So you can measure your lung volumes with a neon, helium, or nitrogen. And as I told you, what they do, they measure the amount of gas that they give you, and they allow you to inhale all the way. And then once you exhale, you measure the amount of gas that you exhale. And then they measure the amount of volume in your lungs from the amount of gas that stay in your lungs and you didn't exhale. Now, why this method is not as accurate as the body technique? As you know, we have some emphysema patients who they have areas in their lungs that the gas does not diffuse into them, right? And they have non-functional alveoli and non-functional bronchial. And therefore, you cannot measure it with a gas diffusion because the gas now will not go to those places, and that will make the lung volume appear lower than what it really is. Because the bullae, for example, you cannot measure it with a gas. You need to measure it from outside with a body box. So that's why the body box or the plethysmography technique is more accurate. Now, let me remind you of how you do the lung volume, and this is from your physiology book. I'll refresh your memory. So remember now, that's the spirometry. So what you do is that you ask the patient to inspire, expire, inspire, expire, inspire, expire, inhale, exhale, and then inhale, exhale, inhale, and then exhale all the way, right? Once you exhale all the way, you reach the residual volume. Then you ask them, inhale all the way. You reach the total lung capacity. Then you ask them to exhale, and then again you go to tidal volume. This area here, we call it tidal volume, remember. This area here, we call it inspiratory reserve volume. This area here, we call it expiratory reserve volume, and this is residual volume. This is the functional residual capacity that I talked to you about. It is the summation of the residual volume and the expiratory residual volume, okay? Now, so what is the functional residual capacity? It's the amount of air that remain in the lung after a normal exhalation. So when somebody is in a body box, you ask him to expire normally, and then you measure the amount of gas that remain in their lungs. And that's how we call the functional residual capacity, and that's how you measure the residual volume. So this is, I explained to you, in normal individuals, functional residual capacity measured by plethysmography and gas dilution, they yield similar results. In patients with obstructive lung disease, such as emphysema and gas trapping, the functional residual capacity determined by plethysmography is higher than measured by gas dilution. And I'll explain to you why. Because the bullae, you can measure it from outside, that makes the volume high. So the difference between the both measurement, we call it trapped gas, which is the gas that cannot you cannot diffuse air through it, or you cannot expire it. We call it trapped gas. Now, diffusion capacity. Diffusion capacity is very important because in your boards, you will 100% get a question about what are the factors that decrease or increase the diffusion capacity. Now, how do you measure a diffusion capacity? Very simple. Remember, in the gas dilution for the lung volumes, you give an inert gas, which is the gas that does not diffuse through the lung, such as nitrogen and helium. In this diffusion capacity, you give a gas that actually diffuses very quickly and very strongly through the alveoli. What is the best gas that diffuses through the alveoli? It's the carbon monoxide. That's why we have carbon monoxide poisoning with small amount of carbon monoxide. In the pulmonary function test lab, we give trace amounts, very small amounts of the carbon monoxide. And what we do, we give it to inhale, and we ask the patient to hold his breath for 10 seconds. Why do you hold your breath? Because you want the gas to diffuse quickly. Now, what you expect is that all the amount of gas that you give should diffuse. So the amount of the gas that you exhale should be very small, negligible, right? Now, if somebody, like patients who have idiopathic pulmonary fibrosis, you give him the carbon monoxide, you give him a certain amount, and then you ask him to hold his breath for 10 seconds. And then you measure the carbon monoxide that comes out of his mouth, and you find it that it's big, then you know that the gas did not diffuse, right? So that is the way we measure the carbon monoxide. So Okay, so now what are the factors that decrease the DLCO and what are the factors that increase the DLCO? And all of them make logic on why you should increase and why you should decrease. Let's talk about the factors that increase the DLCO. First one is polycythemia. Why? Because you have more blood to extract the carbon monoxide, and therefore the DLCO will go high. Left to right shunt, same thing. You have a you have a large volume circulation. When you have a large volume circulation, there is a huge amount of blood that goes to the alveoli, and that blood will actively extract the carbon monoxide and cause the DLCO to go high. Asthma. Why do asthma cause large DLCO? Simple. Because when you have asthma, you have obstruction, but there is no destruction of the alveoli as emphysema. When you have obstruction, then this means when the carbon monoxide goes inside the lung, it's not easy for the carbon monoxide to leave the lung, and therefore it becomes there and it continues to get absorbed, and that causes the DLCO to go high. Pulmonary hemorrhage. When you have blood in the alveoli, the blood in the alveoli will extract the carbon monoxide and cause the DLCO to go high. Muller maneuver is the opposite of the Valsalva maneuver. The opposite of Valsalva maneuver is Muller maneuver. So you try to inspire, instead of expire against a closed vocal cord, you try to inspire against closed vocal cord. That increases the pressure in your lungs and will lead to increase. Exercise, because there will be hyperdynamic circulation, and supine position. Supine position actually causes the blood to increase in the lower and the upper part of the lungs and cause it to extract more carbon monoxide. These are the factors, remember them, that will increase a DLCO. What are the factors that reduce a DLCO? The first one that can reduce a DLCO is anemia. When you have anemia, you have low blood and therefore can decrease a DLCO. Valsalva maneuver can decrease a DLCO. Lung resection, for obvious reason. COPD, not all COPD, mainly emphysema, because there will be destruction of the alveoli and therefore there will not be much diffusion. Pulmonary vascular disease, example, pulmonary hypertension and pulmonary emboli. Pulmonary emboli, there will be no blood supply to certain parts of the lungs that lead to reduction in the DLCO. Pulmonary hypertension, what happens is that there will be increased pressure in the lung vascular area, and therefore the increased pressure will cause decrease in blood flow to certain lung alveolar space and cause reduction in the DLCO. Okay, so these are the factors that will affect the DLCO. You will 100% get questions about this. Now, the respiratory muscle pressures. This is important clinically. Why? Because if you have a patient, for example, admitted with myasthenia gravis or multiple sclerosis, at what point you will assess that the patient needs mechanical ventilatory support? You measure the respiratory muscle pressures and you measure the vital capacity. Once the vital capacity, what's the normal vital capacity in a human being? 5 liters. Once the vital capacity drops below 1.5 liters, then that patient is an impending respiratory failure. And that's how we measure the vital capacity. And then we measure the respiratory pressures. To measure the respiratory pressure, it's a simple closed valve technique. And what you tell the patient is to inhale or exhale against a closed valve, gauge valve, like pressure valve, just a pressure valve. You ask him to exhale all the way, and then the valve will have a gauge pressure on it, and it measures the pressure of that you exhale the air, the pressure of the air that you exhale, or the valve is closed and you inhale and it measures the pressure of the air that you inhale. Now, what's the normal values of the maximum inspiratory and expiratory pressure? The maximum expiratory pressure, because it's expiration, it's positive. The normal is around positive 120 to 150 centimeter H2O. The maximum expiratory pressure, because it's the inspiratory pressure, because it's inspiration, it's negative force. So it's usually negative 120. But any value above negative 60 is good. And that's what, as I told you, that's what we call the NIF, the negative inspiratory force. Now, values usually, they decrease with age, because as you know, the muscle strength decrease with age. And also in females, they are 1/3 lower than males. So that's why the same values you do not apply to males and females. You have to do 1/3 of the values for female. Now, a normal maximum inspiratory pressure excludes inspiratory muscle weakness. But a low maximum inspiratory pressure does not confirm inspiratory muscle weakness. So what they tell you is that sometimes the effort will not be very good. So if it's normal, then the patient does not have muscle weakness. But if it's low, make sure it's not the effort, okay? Now, when the maximum inspiratory pressure reach below 1/3 of normal, then that's when you start retaining CO2, okay? And that's how I actually, patients who have multiple sclerosis, for example, they come to you to the clinic and they're doing fine, their oxygen is normal. So that's why you would ask yourself, when do I think that they need oxygen, or they may need like tracheostomy or BiPAP device, or they go into what we call respiratory failure? When? Now you can monitor their blood gas and make sure that their CO2 level does not rise. You can do that. But a better area to do that is to measure their maximum inspiratory pressure, their muscle weakness. If the maximum inspiratory pressure drops below 1/3, and as I told you, the normal maximum inspiratory pressure is about negative 120. If it goes below negative 40, then that's when I know that the multiple sclerosis patient will start he's going into hypercapnic respiratory failure. And mainly they go into respiratory failure at night. You know why? Because at night, during REM sleep, the rapid eye movement or the deep sleep, which is around 25% of normal sleep, their muscles get paralyzed. The whole body muscle, except the diaphragm, get paralyzed. And therefore, if they have already weak muscles, they will retain CO2 more. Now, maximum expiratory pressure, the expiratory pressure predicts a weak cough. If it's less than 60, normal is 140. If it's less than 60, means that the patient has a weak cough and cannot clear secretions. And this is very useful in stroke patients. How would you know that stroke patient cannot clear secretions? You look at him, you say, oh, he's gurgling in his throat. He looks very weak. You know, he may need tracheostomy because he cannot clear his secretion. He's going to keep coming with respiratory failure. But this is all subjective. If you want an objective data, you need to measure the maximum expiratory pressure. And if their maximum expiratory pressure is low, this means that they have weak cough. So the inspiratory pressure tells you if you have good muscle of inspiration, which is the intercostal muscles and the diaphragm function. The expiration will tell you about cough, because when you cough, you expire. So the MEP measures the amount of cough or the expiration. And that's how you measure in stroke patient if they can clear their secretions or not. Now, airway challenge, I don't know if you will get questions about airway challenge. Just one thing you need to remember about airway challenge, which is, it's dangerous test, by the way. You don't want to do it for somebody who's active obstruction. So any patient who have FEV1 or FVC ratio below 65, you do not continue to give him more bronchoconstriction because they may go into respiratory failure. But remember, it will cause a drop 20%. 20% is the amount of the drop. So, and this is the concentration of the medication. So what you do is that you measure the FEV1. This is the FEV1 on the on the y-axis. and this is the x-axis have the methacholine dose. So you start with around 0.0625, then you go to 0.125, you go to 0.25, 0.5, 1, 2, 4, and 8. The amount of the medication that cause a drop in FEV1 more than 20% is the amount that is positive for bronchoprovocation. So as you can see, this is the 20% here. So what's the amount that cause drop is here, this amount, which is 0.5. If you have any amount 2 or less, then the test is positive. But if it's more than 2 to 4 or more than that, any normal human being, if you give him a big amount of methacholine, they will drop their FEV1 more than 20%. So that's not a positive test. Remember this. So if somebody drop more than 20% when the methacholine dose is like 4 or 8, that's not a positive test. That is normal. Normal individuals can do that. So I'll tell you how to interpret the, okay. So, so results are, okay, normal, anyone who more than 16 drop, that's normal. But for the lab, we usually measure 4 to 16 because borderline, some people, normal people who have allergies, for example, somebody who has allergic rhinitis, they can drop with 4, even if they don't have asthma. So 4 to 16, anything above 4 is usually normal. Now, if somebody drop below 1, that is usually, we call it airway, AHR means airway hyperresponsiveness, or like asthma. Mild, if anyone between 1 and 4, he's usually mild. Moderate or severe, anything below 1. So this patient, he dropped the FEV1 more than 20% at a concentration of methacholine 0.5 milligram per ml. Therefore, this patient has a severe airway hyperresponsiveness or severe asthma. Now, this is the last, I have only 3 or 4 slides left. How to interpret a pulmonary function test. We have to look at obstruction, restriction, and sometimes mixed. Obstruction, if the FEV1 over the FVC is less than the 5th percentile predicted, which is usually in normal human being is around 70%. So any FEV1, FVC ratio below 70% is usually obstruction, okay? Now, some people may not have obstruction, but if you look at their small airway, which is the FEF 25, 75, usually it is less than 70%. Then that patient does not have COPD yet, but he's at risk. Because when you start smoking, that's how you start developing. You develop first small airway disease, and then you go into a large airway disease, okay? Now, you don't need to know the next one, which is a mixed. Now, we sometimes have something, we call it non-specific spirometer, but this is mostly for pulmonary fellows. I don't, usually share it with the residents, but sometimes the FEV1 and the FVC are reduced, but the ratio is normal. And so it's not obstruction and it's not restriction. When you don't have obstruction restriction, you call the PFT non-specific. And around 10% of our PFTs that you measure may be a non-specific. And these PFT have certain interpretation. But anyhow, so this is how you classify severity of obstruction: mild, moderate, or severe. Now, some values, which is the ATS, the American Thoracic Society, take the obstruction at 70%. Some, the gold stages, take it at 80%. In our hospital, we depend on the ATS guideline, the American Thoracic Society guideline, and we look at 70. So if it's 70 or less, it's mild. If it's 60 to 69, it's moderate. If it's 35 to 50, severe. And if it's less than 30, severe. For the gold classification, If it's more than 80%, it's mild. If it's 50 to 80, it's moderate. If it's 30 to 50, it's severe. If it's than 30, it's very severe. So, and that's what we call it gold stage 1, 2, 3, and 4. Okay. Now, so as I said, obstruction, you need to have the FEV1 to FVC ratio is less than 70%. For restriction, you need the FEV1 over FVC ratio above 70%. But you also need the total lung capacity to be restricted. That's the most important part in restriction. And that's why you cannot actually use spirometry alone to diagnose restriction. You need a lung volume technique by either the body plethysmography or the gas dilution. And in the body plethysmography, you need a TLC less than 5th percentile to know that the patient has restriction. Now, this graph here is the most important graph that you guys need to remember. And the reason for that, because that's how you interpret a flow volume curve. So a normal flow volume curve will look like this. If the flow volume curve during the inspiration looked normal, but during the expiration showed some obstruction, then that tells you that this is emphysema. Okay. If the flow volume curve looks normal, but all the volumes are restricted, this is a restrictive lung disease. So this one here, normal. This one here, emphysema, because the inspiration is normal, but the expiration is obstructed. This one here is restrictive lung disease. Why? Because the inspiration and expiration look normal, but they are all shrink in size. So that's restrictive lung disease. So restrictive lung disease, obstructive lung disease, normal. Now forget about those. Let's look at this. This graph showed you that there is obstruction, but where is the obstruction? It's the inspiration. Remember, the inspiration loop is here, the negative deflection. So when you have obstruction during inspiration, that tells you that the problem is extrathoracic. It's the opposite. Remember, if the obstruction is during the inhalation, the problem is extrathoracic. If the obstruction is in the expiration, the problem is intrathoracic. I'll give you examples. Now, what's the difference between intrathoracic and extrathoracic? You know, it is the thoracic inlet. Where is the thoracic inlet? It's at the level of the vocal cords. That's the thoracic inlet. Any problem above the vocal cord is extrathoracic. Any problem below the vocal cord is intrathoracic. The vocal cords themselves is both intra and extrathoracic. Okay? So I'll give you an example. If you have a thyroid that is impinging in your upper airway, not on the trachea, on the upper airway. It's not retrosternal thyroid. It's thyroid that is obstructing your larynx. الحنجرة. ضغط على الحنجرة. When you have this, then when you امتى بصير المشكلة? When you inhale. يوم ما تاخذ نفس بصير عندك obstruction. عيالك اخذت النفس وراح الobstruction، يوم ما تتنفس برا، يوم ما تطلق زفير ما بصير obstruction. فعشان هيك extra thoracic وين بصير obstruction during inhalation. بدي اعطيك مثال ثاني. يوم يكون عندك تيومر في التراكيا، big tumor occupying the trachea، يوم ما تاخذ نفس عميق فيش مشكله، ما في obstruction. بس يوم ما تطلع النفس بصير obstruction. فعندك الobstruction بصير خلال expiration يوم يكون عندك intrathoracic problem. هلا لما يكون عندك البروبلم في الفوكال كوردز نفسها زي vocal cords paralysis، شو بصير عندك؟ بصير fixed obstruction. يعني بصير الجراف اللي هو هذا زي السكوير بنسميه. الobstruction بصير during inspiration and expiration. I think that is the last slide, and after that I have some questions. Let's go through the questions quickly. and then I will finish. So which of the following is used to follow disease severity in COPD? For chronic obstructive pulmonary disease, what do you for disease severity, what do you focus on? Is it diffusing capacity? No. Is it degree of responsiveness to bronchodilator? Also no. Is it the forced vital capacity for the obstructive lung disease? No, it's the FEV1. The FEV1 is the one that determines the degree of obstruction, mild, moderate, or severe. If it's normal, above 80%, it's mild. If it's between 50 and 80, it's moderate. If it's between 30 and 50, it's severe, and if it's below 30, it's very severe. Another question. 22-year-old female present to your office for follow-up of recurrent attacks of acute bronchitis. You suspect asthma. Which of the following would you include in your spirometry testing to diagnose asthma? Okay. Is it diffusing capacity? No, طبعا لا. If no obstruction is present, you add bronchodilator. ممكن. If no obstruction is present, you do imethicillin challenge. ممكن. Flow volume loop طبعا لا. هلا السؤال هون مين أكتر specific to diagnose asthma? Is it the bronchodilator response ولا imethicillin challenge? الميثاكولين challenge is لأن البرونكودايلاتور ريسبونس في السي او بي دي كمان ممكن يكون positive. Okay, so the answer to this question is C. Last question. 72-year-old male patient admitted to the ICU. He has respiratory distress. You obtain a chest X-ray in the emergency room. The chest X-ray showed bilateral pulmonary infiltrate. Then you did a DLCO test, and the DLCO test became elevated, increased. What is the most likely diagnosis? Pulmonary edema, hypersensitivity pneumonitis, venous thromboembolic disease, alveolar hemorrhage, or interstitial lung disease. Okay, raise your hand if you think it's A. I don't see any hands. Raise your hands if you think B. What about C? PE? PE can decrease or increase. Okay, what about D? Raise your hands. Okay. What about E, interstitial lung disease? No. So yes, so you are right. So alveolar hemorrhage. Pulmonary edema, by the way, decrease. Congestive heart failure, early on, it increased DLCO, but later, when there's pulmonary edema, it decreased DLCO. Hypersensitivity pneumonitis decreased DLCO لأنها it's interstitial lung disease. PE decreased DLCO, and interstitial lung disease decreased DLCO. And this is the last slide. I hope that you guys enjoy the lecture and you understand it well. If you have any questions, email me, please. Rana have my email. And if you have any questions now, you can text, please. I will wait a few minutes for you guys to text if you have any questions. Okay, I can see some questions here. Okay, no, we can hear you. Okay. Okay, I'm on my messenger now. If anyone has a question.
شكرا دكتور، يعطيك العافية. يعطيك العافية دكتور.
If no questions, just write no questions and thank you, and then I will